Traditionally, when a patient at the time of diagnosis, usually they have a number of factors that bring them to medical attention, such as bruising, bleeding, infections, and they're started traditionally on high-dose chemotherapy and to abate the underlying leukemia. And depending on what type of patient factors, they may need to adjust that chemotherapy, and it's a very intensive experience both for the healthcare providers as well as the patients. And then depending on their subtype, now on top of that sort of traditional approach of chemotherapy upfront or at the time of relapse, or if a patient becomes refractory to that therapy, understanding the mutations such as FLT3 positive mutation, of which about a third of patients with AML will unfortunately experience during their disease progression, becomes important to identify, because the particular genetic factors that are driving the patient's leukemia initially, or when they become refractory to therapy or at relapse, may evolve over time. And with more targeted therapies, you're able to tailor the therapy for that particular patient. One of the things that is becoming apparent is that having more genetic testing, particularly understanding what the drivers are so that the therapy can be tailored, is an important part of the overall treatment paradigm for patients, either pre-transplant, on the way to transplant, or as the initial therapy. But it's traditionally the hematologist that the initial therapy and diagnosis that would be driving those genetic testing.